Thank you for coming. My name is Daniel Piñeiro. I'm the current president of the World Health Federation, and today we will discuss some topics about. Could you hear me or not? Could you hear me? No. Oh. High level? Yes, but I cannot change that. Okay. So the idea is to discuss some topics about Chagas disease. I can see many people with a lot of experience in the public, so I will ask you to be very active during our session. Not only the panelists, but you are the main here. So let me, first of all, to introduce the name of this session. The name is Unravelling the Challenge and Solutions in Chagas Disease Management. We have today, we will have 1 hour for discussion. And let me introduce the panelists. I'm an old man, so I will start with the lady. Dr. Clara Saldarriaga from Colombia. She is professor of cardiology in the cardiovascular clinic Santa Maria, University of Antioquia, Colombia. And she is the current president of the Colombian Society of Cardiology. So thank you so much for being with us. You have Professor Tom Ribeiro. He is the professor of Internal Medicine Department, School of Medicine, and vice director of the Center for Innovation in Artificial Intelligence for Health, the Federal University of Minas Gerais, Brazil. And he is now chairing the expert group of neglected cardiovascular disease in World Health Federation that is very focused in Chagas and rheumatic heart disease. So, thank you, Antonio, to be with us. Dr. Rick Tarleston, he's head of the Tarleston Research Group in the University of Georgia's Department of Cellular Biology, University of Georgia, United States. Thank you, Rick, to be with us. And finally, Dr. Bruno Ramos Nascimento, from the Federal University of Minas Gerais, Brazil. Thank you. So, the idea, I have some questions for the panelists, but this is an open discussion. I have some points that I want to share with you. If I will say that without any paper. Chagas disease is a very, very important disease, especially for us in Latin America. But let me say that now Chagas disease is a global disease. It's a global disease. It's not more a tropical disease. It's not more a Latin American disease. It's a global disease. Do you know how many people are here in the United States having Chagas disease? 300,000 people here in the United States. 40,000 in Spain. And there are cases in Japan, Australia. So it's a global disease. I don't know if the panelists agree with that. Agree? Thank you. Absolutely. It says, the second point I was to highlight is that the diagnosis of Chagas disease is very, 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 very low. The Pan American Health Organization states that 90% of Chagas patients have no idea of the diagnosis. 90%. So we have a very big problem there. Third point that I want to highlight is that we have only few tools for treatment of Chagas disease. Other point is that the comorbidities. We are treating patients with Chagas disease and hypertension and diabetes and heart failure and coronary heart disease. So this is the scenario we are moving around. And just to finish, the investment for research in Chagas disease is very, very, very low. There is a very nice paper from Brazil that look for the percentage of money assigned for Chagas disease research. If you take all the neglected disease, not only cardiovascular, but all the neglected cardiovascular, neglected disease like malaria, like many others, the investment for Chagas is 0.67 in 10 years. So we need to put Chagas in the agenda of governments to increase investment in Chagas disease. So I will start with some questions. I will start with Tom. Here I have my script. Tom, could you tell us something about race study and what is the aim to do in terms of estimating the health burden of Chagas disease, and why are accurate estimates of the burden currently not available, and why is it important to undertake the study?
Yeah, so first thank you, Professor Daniel and the World Heart Federation for the invitation and the audience. So Chagas is such a neglected disease that it does not appear in official statistics of each country. So when you go to the death certificates, you can see that first, there are places in Latin America where we have 1-2% of the population infected by Chagas disease. But when you go to the death certificate, it appears in very few cases. So patients, they have Chagas disease, they die due to cardiac disease in consequence of Chagas disease, but Chagas disease does not appear as a cause of death. For example, in Mexico, we have something like 40 deaths in the whole country for Chagas disease in 1 year, in a country in which 0.8% of the population are infected. So there is a under notification of Chagas disease as a cause of death, that it's the same process that occurs when you go to a heart failure clinic in several places, or when you go to a community in an endemic area. People do not know that they do have Chagas disease. So this impacts directly in how the burden of Chagas disease is calculated. The burden of disease is a concept that is being used in health policy to define priorities and how to spend money, and they consider the number of deaths, the amount of life that you lost because you die prematurely due to one disease, and the amount of life you live with disability because of this disease. There are inputs for this calculation that includes the prevalence of the disease in each country and the number of deaths. If both numbers are underestimated, what happens is that when you consider the list of disease, of cardiac disease, Chagas disease seems to be a very, very low importance disease because they are not being counted. And so the cost of the disease, the social cost, the economic cost is not being considered. This is a reason that first, the Pan American Health Organization is reviewing their statistics on prevalence of disease. It seems that the real prevalence is higher than they have considered in the past. And we are reviewing through meta-analysis that is being presented in this Congress, both in endemic countries and non-endemic countries, and try to understand how this under-notification impacts in the burden of disease, to recalculate the burden of disease with more realistic numbers regarding the prevalence of the disease and the burden of diseases. So it's a way of giving visibility to Chagas disease for the health policy, because if it has an impact in terms of burden of the disease, economic burden, health burden, it needs to be treated and needs to be cared by the health systems. So this is the RAISE study. We published the first meta-analysis. We are presenting here. Bruno just presented one of them in congresses and papers, and now we are going for the final papers of the burden of disease.
Thank you so much. I will move to Dr. Dalton. And my question is, what does the current landscape of therapies for trypanosoma cruzi infection and Chagas disease look like? And how might this relate to some of the political and health system challenges?
Well, thanks for the question, and thanks for the invitation to be here. So I'll start off by saying my desire is that Chagas disease in 20 years won't be discussed at this meeting, because the problem is diagnosis and early treatment of infected individuals so that they don't develop disease. So managing disease, I hope, will become a thing of the past, but we need therapies for that. And I think we also need good therapies to deal with the issue of diagnosis, because there's very little importance in diagnosing infection unless you have a way to prevent disease development, so a treatment, right? So if we have effective treatments, the incentive to diagnose and to identify those individuals is greatly increased. So one issue in the Chagas field has been we have two drugs that have been available for more than almost 50 years now. They have moderate to sort of unpredictable efficacy. We've had 5 or 6 clinical trials of new drugs, which have all been failures over the past 15 years. And that gives the impression that this is an insurmountable problem. And I think that's the wrong impression. So to directly answer your question, I think there are at least 2 very good drugs on the horizon. One is a compound that I've had a role in working on. The reason I'm very optimistic about this particular compound is, in addition to having 300,000 infected humans in the U.S., we have huge numbers of infected dogs and also large numbers of infected non-human primates in primate facilities in the southern U.S. And this compound that has recently been tested in non-human primates with long-term naturally acquired infections cured 100% of those animals. And so there's, at least 3 or 4 or 5 more years of work to be done on that particular compound. But I'm very optimistic that it or another one in that class of compounds will come into use and will get into humans sometime in the next 4 to 5 years.
So just a comment. For you, it's important to put Chagas in the agenda now, just to can't forget it, let's say, in 30 or 40 years. I will not be here to see that, but I hope. I'm going now to Dr. Saldarriaga from Colombia. And my question is, let me see my paper. Because, Clara, you are Clara. No, my question is about, you have a good experience in Colombia with a big registry on Chagas disease and heart failure, and not only in Chagas, but in heart failure in general. Could you explain us if there is some differences between Chagas disease and other etiologies of heart failure?
So thank you very much, Dr. Piñeiro, and thanks for this space to discuss our data from Colombia. So when we start reading what is what is published before, you can see that, for example, for inter-CHF registry, you can see that mortality is higher for heart failure in Africa and also in Latin America. So why is that? Is this data enough, or we need something else? So in 2016, a group of our National Society of Cardiology decided to have our own data to design our registry to see what was heart failure as a problem in our country. So we start with Recolfaca registry that I'm very proud to say that is like a model from some other countries in Latin America. We start to recruit patients with heart failure, but not just in Medellin, Bogota, the places where we have very specialized centers. So we go to every region of Colombia. We have patients from the Amazonian region and also from small towns to see what means heart failure for us. So we now are in the third cohort of this registry, but we have a really nice analysis for the first one when we decide to look for patients with Chagas heart disease. So I can tell you that 3.6 of our population that was recruited in this registry had Chagas heart disease. When we look to this population, we found very interesting things. For example, these patients are younger. They are 6 to 7 years younger than the whole population of our Recolfaca registry. Those patients, they don't have as much comorbidities as the rest of our heart failure patients, but I think that the most sad thing are that those patients had a twice risk of dying than the rest of our heart failure patients. Most of them are from rural areas of Colombia, and I think that opens the door to learn a little bit more about our Chagasic patients in Colombia. I can tell also that today we have more interest in those patients, but for example, I work in research. I recruit patients for so many heart failure clinical trials, and when you ask a steering committee, can we take a look at the Chagas population of patients that were included in Latin American countries in your trial? The answer is always like, well, we don't have this data, we don't look at that, so I think we can do things better. For example, I'm really happy that now we have some trials looking for the guide-directed medical therapy specifically in Chagasic patients. One example is Parachute trial that maybe is going to present the results next year. So I think that we need to push more to have information about Chagas patients in our countries, and also to push to have results in this specific population in clinical trials.
Thank you, Clara. My last friend, Bruno. Bruno is from Minas Gerais. We have not good relationship about soccer. About soccer with Minas Gerais. What's my question is, what are the most pressing research priority of our areas of focus for advancing or our understanding in Chagas disease in Brazil, especially? And how can we research finding be translated into policy and practice to improve health outcomes for affected individuals?
Okay, so thank you, Dr. Pinheiro, and thank the World Heart Federation and the scientific committee for inviting me for this session. And it's very good to know that we're keeping discussing Chagas disease here in the ACC. And I agree that in some decades maybe we will not have this kind of session, depending on how research and how healthcare goes. But at this point, at least in my opinion, I don't know if the panel agrees with me, but I feel that for the new generation of physicians, even in Brazil, we're a little bit forgetting about Chagas disease in some aspects, specifically related to the need for a prompt diagnosis, the early diagnosis allowing for interventions to prevent disease progression, the knowledge about simple things, for example, the basic and the very initial EKG abnormalities that can tell that a person may have Chagas disease based on those specific findings over there. But in terms of research priorities, I have to say that Chagas disease does not have so intense investments in terms of the industry, because there are no devices being tested. That's one point. As we mentioned here, there are not so many new drugs being developed for Chagas disease, which basically drives the investments of the industry in a disease. But on the other hand, I see that there's a huge importance of academic research to address questions related to Chagas disease, and I believe that some of the key points for this are related to implementation science. So I think that educational programs, educational projects, research projects related to Chagas disease, expanding the knowledge about the disease, the diagnosis, and the early treatment, especially for people working in the public health system, as in Brazil we have a primary care system that's widely available in the country. The second point, and now I have to mention all the extensive research done by Dr. Ribeiro. We have the AI right now, the artificial intelligence, and we can take advantage of a lot of things related to technology to improve the care for patients with Chagas disease. Right now, there's a development of automated systems for the diagnosis of major EKG abnormalities, and in Latin America we have huge databases of EKGs from Chagas disease patients, so it's a great opportunity for research, and it should be prioritized. Also, I think that we need to think about the quality of the surveys that we have. Before doing interventional studies, we need to know better about the epidemiology of Chagas disease. In this aspect, the RAISE study is bringing some, not only some answers, but some very good insights about the quality of data that we have. We have very limited data about actually very limited surveys about Chagas disease in non-endemic countries. The quality of data is low. Even in Brazil, in Latin America, we did this meta-analysis presented today with over 70 studies, but the inclusion criteria and the methods are very heterogeneous. So I really think that we need to update the prevalence estimates, the population-based surveys, and also the estimates about the prevalence of clinical forms, and especially longitudinal studies about the evolution of Chagas disease and the key predictors to identify the patients at high risk. And all this does not make sense if we do not implement this research. So a deep connection between investigators, the medical societies, and the health systems is crucial to implement everything that we find in this type of research.
Thank you so much, Bruno. Now I want to open the discussion with you, with the audience. Any question, any comment? To please introduce yourselves and make your comment. Do anything you want.
Yeah, Ivan Mendoza from Venezuela.
Yes.
I agree completely with you. It's very hard to find Chagas disease patients in trials and data on devices, on medications. Not only because it's challenging for the big companies, sometimes outside of the Latin America, but this is not a problem for Latin America. This is a problem, it's globally. That was a product of exportation. Now it's everywhere. It's in Japan, in Australia. So, and not only it's interesting because these patients have poor prognosis with the same medication. They have worse prognosis with any device. So maybe there's also a barrier of not so interest to include these patients because we know that they might do worse. So that's another challenge on top of obviously the forgotten disease.
Thank you so much, Dr. Mendoza. Dr. Mendoza made a very nice meeting, I think 2 days ago in Miami about this issue. There is who first? You know. No.
Thank you so much. brilliant expressions. I have many.
Now, introduce yourself
More,
because
my name is Bolivar Science from Ecuador. We are neighbors from Clarita Saldarriaga. And I'm very concerned because we have 3 persons here in my country what we're working with heart failure. And we're doing registers that we don't have no more or a little bit patients with heart failure with Chagas as a etiology. So I was listen to the work for Clarita, and maybe we have the problem that first the underdiagnosis, and after maybe the patients are only remaining with heart failure in the Amazonic part, because in our part, I'm from Quito. In Quito, we don't have any Chagas disease there. And I was studying Brazil in Rio de Janeiro. And Rio de Janeiro was a lot of patients with etiology of Chagas disease. How can you explain that? Or you think we have to do another type or a strategy to take more patients with Chagas disease?
Thank you. So he's telling me that I will be 80 and everybody is still going to call me Clarita. My answer is that we don't diagnose the diseases that we don't have in our mind. I have the opportunity to have a meeting with a group of cardiologists from Bolivia, and they were telling me, we have no ischemic cardiomyopathy in Bolivia. And I was like, why? Coronary artery disease is everywhere. And they tell me, no, everything is Chagas. So maybe the same is happening in your country and in my country. Maybe we are thinking that everything is ischemic heart disease and we forget to test our patients for Chagas. So my answer is we need to think about diagnosis of the disease. If we don't do that, maybe we are not going to get those patients treated.
Only to say that, yes, you need to test. Some of them should be there. Or since a disease, I was talking with Clarita, sorry for this, and about Chagas disease in Colombia, because she's from Medellin, and most cases came from the east part of the country. So there is a regional variation in places that is very important. But what we are, Bruno said very briefly, we are trying to implement using this NIH grant is to screening for Chagas disease using DCG, using AI ECG for finding Chagas disease in Chagas cardiomyopathy patients. So what we have this large data set of 2.4 million ECGs. We have the self-reported Chagas disease. We have the cohorts that we can improve this. So we trained a DNN, a deep neural network algorithm, to find, like the Mayo Clinic people did for aortic stenosis, but for Chagas disease. So we showed that the accuracy is very good for Chagas cardiomyopathy, not so good for Chagas disease without ECG abnormalities. But we are testing this strategy now in the state of Minas Gerais. I know that we are in the middle of the epidemic place, but it's and now we did a pilot study, and we included questions about these questions, standard questions, if persons knows who have a family, a person family of Chagas disease, knows the bug, or so three questions about the epidemiology, and add the ECG or AI ECG, and now we are calling these persons to perform this serology. So we are finding dozens of patients. There is some rate of false positive, something that the predictive value is something like 40%, but we are finding many patients that do not know previously that they have Chagas disease. So I think that maybe we'll need to actively search for the serological diagnosis for patients in heart failure clinics in epidemic regions, or using these tools like the AI ECG and others to find these patients. I'm sure they are there.
Thank you so much.
May I say something?
Yes.
Just to say some words also about what Professor Tom is saying, that it's very important thinking about the research priorities that you asked me about.
I will.
This overlap between different research strategies. For example, we have two programs that are supported by the World Heart Federation and with different diseases, but with a similar aspect related to education about health. So we have rheumatic heart disease, strategies for education, and we can expand that for Chagas disease, which is very important. And the same we're doing for the echocardiography, trying to combine the strategies, what we've been doing for rheumatic heart disease with Chagas disease and utilizing AI for that.
Let me add that the World Heart Federation is supporting for many years color hearts for rheumatic heart disease in Africa, and it's a very successful initiative there. So we have a question from Dr. Bolberg.
Yes, I think this is discrimination. Well, one of the risk population in Chagas, I think, is the pregnant woman. And in Argentina, it's obligatory to test all pregnant women. And this is the moment where the drugs works. But not in all countries in Latin America. It's obligatory to test, to make serology of this population. What do you think about it? And perhaps in Mexico they don't check all women, and I think there's Chagas also.
Do you want to take this question?
Yes, I absolutely agree. So the World Heart Federation, they have a fascinating paper that is called the Road Map for Chagas disease. And one of the main topics is the secondary prevention of Chagas disease, where they state that it's so important to test pregnant women. I agree with you that in endemic regions and in some places we should do that with every pregnant woman. I have the opportunity to work with the Lancet Commission for Cardiovascular Disease in Women, and one of the topics that I just make them to have on mind is that Chagas is important for the health of women because of the risk of the congenital transmission of the disease. So I think that this is a topic that we need to bring also in the discussion about how can we prevent the disease.
Thank you. Rick, please.
Yes, I agree that diagnosis and treatment is important, and congenital transmission is an issue, but it's relatively minor issue in the overall scheme of infection in Chagas disease. It has a high impact because it infects newborns, right? But diagnosis and treatment well before the age of being able to conceive is really what would be the highest impact, rather than focusing more attention just on women. I think all young children, young adults, male and female, should be screened and treated early.
Thank you so much. Any other question or comment from the audience? No. So I will go back to Dr. Saldarriaga and to ask about what you consider are the main barriers for care access of people with Chagas disease.
I think that the healthcare system also had barriers for patients with Chagas to get access to care. Because as I mentioned before in our registry, those patients are from rural areas, so it's a challenge to get medical care that is related to the socioeconomic status of those patients. So we don't think about the diagnosis of the disease, but when those patients are diagnosed, they don't have the same access to care that, for example, population that lives in urban areas compared to rural areas. So I think we also need to give better access to care to those patients if we need to improve the treatment.
Thank you, Clara. Let me know, anybody? You? Yes, why not? Bolivar.
You talked to us, that in United States we have 300,000 people with Chagas disease. How can it be possible? Is that you have an endemic part of origin of Chagas disease, or persons who are for immigration from here?
Well, those are estimates of 300,000, but almost, I would say 99% of those are immigrated. But that is almost totally because of housing in the U.S. Okay, the southern U.S., we work in regions in Texas where 50% of the animals and 50% of the dogs, of people's dogs, including government working dogs and ranch working dogs, are infected with T. cruzi. Okay, the people that handle those dogs and live with those dogs are not infected because they live in a nice house, right? So the parasites are there, the vectors are there, the infected animals are there throughout the southern U.S., but human cases in the U.S., new cases in the U.S., are relatively rare, but it's because of the interaction with the vector primarily. And I think that also bodes well for just economic development in Latin America is a solution for Chagas disease. I mean, housing simply would totally solve the problem, almost totally. So, thanks for that question.
Thank you so much. I will go back to Bruno. Bruno, how do you think the socioeconomic factors and disparities influence Chagas disease risk, access of care, and health outcome in Brazil? And what are the strategies that can be implemented to address this problem?
Yes, thank you for this question. It's interesting because in Brazil, we not only in Brazil, of course, but in almost every developing place, we deal with disease very socially mediated. For example, in the cardiovascular side in Brazil, we struggle with Chagas disease. We struggle with rheumatic heart disease, being responsible for over 50% of the open valve surgeries. So there's a clear social mediation of Chagas disease. At first, as we mentioned here, in terms of the habitation of the patient, the types of houses, even though in Brazil it has been proposed, right, Tom, that the vectorial transmission is going very low or is virtually eliminated. Brazil is a big country, and as we walk through the Brazilian states, we see that there are different countries. There are like different countries inside the same state, and sometimes we feel that this vectorial transmission is not eliminated. It's also an observation from our outpatient clinics in this setting. So the disease is very social, but there's a huge impact not only from the people's house, but also from the access to healthcare in every aspect. In Brazil, we have a good penetration of primary care. Sometimes it's heterogeneous between the Brazilian regions, but it's overall good since the 1990s. But there's still lack of education about when to screen for Chagas disease, when to suspect Chagas disease, and to identify the population at high risk of Chagas disease. The second point is even when the access to primary care is relatively good, we have a difficulty with the secondary level of care. So this may contribute to higher mortality. Sometimes we see that people identify the patients with major EKG abnormalities, but after that they don't have access to simple tests, for example, an echocardiogram or even the clinical follow-up in a specialized clinic. So this also impacts the outcomes of patients with neglected disease as Chagas disease. And from your second question, how to address these points, I believe that it's something that we have discussed here. At first, a good penetration of public health care and primary care, not only to have healthcare, but to educate the healthcare providers about the existence and identify the populations that should be tested and should be assessed for Chagas disease, and also to develop strategies to decrease the costs of secondary care, allowing for more people to have access to specialized personnel, specialized physicians for the care of advanced disease.
Yes, I think that when you go to the observation of the worst prognosis of Chagas disease patients with heart failure, we should consider that part of this worst prognosis is related to the fact that they are, in general, they are poorer, they have less access to health services, to quality of drugs they need. So there is probably something related to the physiopathology of the disease, because there is an extensive involvement of the heart and the conduction system and arrhythmias and so. But there is also this socioeconomic component in the worst prognosis of Chagas disease. So it's a way of punishing twice or three times the same patient. They got the disease and they cannot have access to how they should be treated.
You? No comments? No questions? So let's go back to Rick again. Do you think, Rick, that Chagas is a solved disease? And if so, what barriers need to be overcome to develop and ensure widespread access to an effective treatment?
Well, it's not a solved disease, but solvable, right? Yeah, I think it really is a solvable problem. Transmission of this infection that causes the disease is not an efficient process. It's not like malaria. If you go outside in the rainy season, you get bitten by a mosquito, you're very likely to be infected, right? You can be bitten by triatomine bugs many times and not get infected by T. cruzi, because it's not transmitted through that bite, okay? And I think the situation in the U.S., as I just mentioned, says that it's a solvable problem, okay? We have parasites, vectors, infected animals, but a very low number of infected people who get infected in the U.S. And that's an economic development issue, right? How does that translate into other countries besides the U.S.? Again, I think it comes down to simply diagnosing and treating early, so we're not, the subject of this discussion here is on managing Chagas disease, right? And I think what we don't want to be doing is managing a disease state that results from an infection that can be prevented or cured. And so it basically comes down to having good drugs and having routine diagnostics that are done yearly at a very early stage in communities that are at high risk of developing infections. And, that sounds simple. It is relatively simple compared to a lot of other diseases. I don't think malaria is a solvable problem. I think it's too complicated, it's too big, it's too many issues involved. I think it's going to be very hard to solve it as a human health problem. But I think Chagas is solvable as a human health problem.
Sorry, my comment is let me say that in my country, I'm from Argentina, poverty is now more than 45%. So the problem is we can solve it, but it's not so easy. So any other, Dr. Mendoza? Dr. Mendoza and Dr. Mendoza. There are two Mendozas. And there is another one Mendoza there. Three Mendozas.
A comment. Another problem, oral transmission in Chagas disease is different in Brazil, Colombia, and Venezuela. It's very important also. A new way to transmit this oral transmission is more severe. The disease, 75% had acute disease with oral transmission.
Yes, this is very interesting because there are some special cases in Venezuela, in Colombia. In Colombia, I'm not sure in Ecuador, but could be too. Any other comment? You, sorry.
My name is Vicente Villacreces from Ecuador. I'm from a city or region in Ecuador where maybe 3 or 4 decades before somebody make a screening and found that we have a area, my city, where Chagas disease was endemic. But 30 years after now, maybe we forget Chagas disease. And I think that the first thing that we have to do is that we are doing now. Put the issue again on the table and see the importance of the problem. And I share the wish that doctor said that this sickness in 3 years doesn't exist. That is we wish, but we have to put the issue again on the table, and we have to make the screening. I would like to ask to Bruno or Dr. Saldarriaga, what group of people, of the population, do you think that we have to screen? What group? Because it's difficult to screening everybody. Okay, what group do you think that we have to screen to know the real problem?
Well, I will answer that patients that live in endemic areas is very important to test them. And also, when you had someone with heart failure in our countries, I think that it's obligatory to think about this etiology of patients. So you should test those patients also. And I'm very happy to hear about the initiatives that you had in Brazil with the EI in order to see those patients that are there just in the cities and everywhere, and we don't know that they have Chagas. I think those strategies also can help us to get more diagnosis of the disease.
Yes, I truly believe that we can set up a set of variables that we can take into consideration for screening. At first is the endemicity of the area. I think it's the first one. The second one, we can think about a set of socio-demographic variables of that specific region and the type of house that region. Very poor houses, people living in very underserved situations should be screened. The third point is the family members. There's a great family coincidence of Chagas disease, and this I believe that this indication is not only for endemic countries, but from our meta-analysis on Chagas disease in non-endemic countries, Dr. Tom is going to present on next Monday. We see that the family members are a great opportunity for screening. And we need also to think about the ideal scenario. We need to think who to screen, but not only who to screen, but also the best opportunity for screening. So also from data from our meta-analysis, I think that pregnant women, they represent a great burden of Chagas disease in non-endemic countries. So I believe pregnancy is another good opportunity for screening. And thinking about endemic areas, I think primary care is the solution. Identifying in Brazil we have a grading of vulnerability, social vulnerability for every primary care setting. So I truly believe that the penetration of primary care and the existence of community health workers may improve the effectivity of Chagas screening.
Only to say that if you do 4 questions, you are from an endemic area, have you seen the bug? Someone in your family has Chagas disease, and did you live in a house of wood or not the poor houses? If you get 3 of these answers, you have something like odds ratio of 8, 7, 8 of the chance of having a positive result increases a lot. So I do not know if it's feasible. We are doing this in this ECG system, so we are doing these questions to increase the pre-test possibility of, but only to say that this would be a very reasonable strategy in endemic areas to search with 3 simple questions who are the higher risk of patients to be screened.
Thank you. Questions, comments? So, just to finish. No, stay. Wait. I would like to ask each of you to give a very, very short message, the main message for all of us about Chagas disease and the future of one thing that for us from World Health Federation is very important, that is implementation, how to translate science in real world. So, 1 minute for each of you just to finish. I will start with Clarita.
I will give you a very short answer. Advocacy. We don't think in the disease, we don't diagnose the diseases that we don't have in our mind. So we need to work in advocacy.
Early detection and funding for that. I think that's funding for all of these initiatives that we're talking about are so limited. But if we're going to deal with this as an infectious disease, there needs to be funding for routine diagnosis across large populations.
I would say health education and also the collaboration between different sectors, science, medical societies, the governments, and also non-profit organizations about Chagas disease to increase funding, to increase awareness, and to increase the penetration of what we find in research to translate into real medical care.
I have to finish with access to care, so with access to health care. It's necessary for the diagnosis, but also for treating the specific treatment, and also access to more advanced care for advanced cases. And on the very brief, I review a paper from a colleague from other country, and then he did 15 years of all hospitals' claims for Chagas disease, and I could not find one ICD implantation. It was from the public system, so it's impossible. We have severe case of Chagas disease, and no one needed an ICD. So there are the access question is very important also.
Please.
Maybe one more.
Yeah.
We cannot do a lot without the support of the public health system. It's impossible. So we have to push the public health system to be involved in this effort.
Thank you so much. Any other comments? So, my last remarks. Let me say that World Health Federation I know you all know what's the World Health Federation, but World Health Federation is the union of more than 240 different societies, foundations, and group of patients around the world from more than 100 different countries. And we are very focused in implementation. We are very focused in implementation. So that's why we build a lot of material for Chagas. Our roadmap, the expert group that Tom is chairing now, the recommendation for Chagas disease echocardiogram, the race, we are supporting race. So we are very, very implicated with the Chagas disease. And I invite you to visit our webpage for looking for this material, but also to see our strategy and our vision that we launched. Our vision was from 2 years ago, and the strategy is now this year. And let me say that we have 4 main pillars, but one pillar is equity. And we as Latin Americans, we are living in the most unequal continent of the world. So, as Dr. Saldarriaga said, we have to advocate. To advocate, our level is World Health Organization, but we need our members. We need you to advocate in each community, each country, each province, anywhere. So, just to finish, let me thank Novartis for supporting this Heart Cafe. We are very, very proud to have them supporting us in this activity, and I'm very pleased to have this panel. As you can see, they are much better than me, and in my case, I will ask you to forget my interventions, but to remember all they say, because they say very important things, and our focus are finally our patients. So we are here to work for them. Thank you so much. Thank you, Clarita. Thank you, Rick. Thank you.